Hey everyone, welcome to the latest edition of Phoenix Children's Live. I'm your host, Peter Ballester, Senior Brand Manager here with Phoenix Children's. Today we're going to be talking about craniofacial care and treatment at Phoenix Children's. So today with me are the Plastic Surgery Division Chief, Dr. Devinder Singh, and Barrow Neurological Institute at Phoenix Children's Associate Program Director of Neurosurgery, Dr. Ruth Bristol. Thank you. And Dr. Bristol just came in on a plane, so you're good. You're all good, right?
Good.
Yeah, you had enough coffee?
Yeah.
You had too much coffee, right? Okay, all right, well, very good. So real quick, always, like I say before we start, we're live, so leave us comments in the section below. We'll try to answer them during if we can, if we get them. If not, we always answer them afterwards. So please, we love questions. And if you're out there, give us a like, give us a love. We even like the little hearts here and there, so please do that as well. Again, questions are accepted. So with that, we'll get started. Always the hardest question is, and I'll start with Dr. Bristol, since you had your coffee. Tell us a little bit about yourself with regard to kind of this, what you do here at PCH for craniofacial craniosynostosis.
So I realized just about a week ago that this is my 10th year doing craniofacial surgery. It is, yes, a decade.
Nice.
So I started my practice back in 2008, and I came over here in 2011 with the big move from St. Joe's to Phoenix Children's. But I have been part of the Barrow collective craniofacial team for the previous 3 years as well.
Okay.
And so that is the major part of my practice, is the craniofacial stuff. It's what I enjoy the most. I do have a varied neurosurgery practice, so I take care of all kinds of things.
Yeah.
But that's sort of one of the areas that my research is in, and something that I really prioritize in my practice.
Excellent. We're so glad to have you. So thank you very much for being here today. Dr. Singh.
So I've also been part of the Barrow Clefton Craniofacial Center and operating at PCH since 2006. And we primarily brought my practice over here also with a transition in 2008.
Mm-hmm.
And I joined officially here last year, and happy to be building a division. My specialty is in craniofacial, so I treat craniosynostosis, but also cleft lip and palate, any type of congenital facial anomaly within our division.
Awesome, thank you guys. All right, so let's talk a little bit about commonality here. I mean, I think craniofacial, that kind of umbrella kind of got really popular with the movie Wonder, with the book Wonder, right? Everybody knows that one. But let's talk about kind of how truly common is craniofacial, craniosynostosis, all those kind of things that fit under that world. How common is that in children, and kind of what do we see at Phoenix Children's on that?
So I think that by far, if you look at craniofacial anomalies in general, cleft lip and palate is the most common, and the incidence is 1 in 600 children in live births. And then craniosynostosis, which is the condition that Dr. Bristol and I treat jointly, the incidence is 1 in 1,500 to 3,000.
It's actually fairly common, right?
It's fairly common,
okay.
And of those, the vast majority of children are what we term non-syndromic. They have isolated craniosynostosis, which is the early closure of the seams between the bone plates.
Okay.
And then probably about 10 to 15% are associated with syndromes, which it just not only affects their head, but affects their face and their facial growth as well.
That's how you identify syndromic, is when
right.
There's more involvement in it, basically.
Right.
Okay. Do we ever see this in utero, or is this something that happens after birth? Or do we ever see these kinds of things? Can you see it in utero or no?
You can.
Yeah.
We've had just a handful of patients where it's been caught, but I think now with 3D ultrasounds that are getting done, for call it 4D now, I think that they're actually catching more of them.
Okay. So in that case, that's typically not something you do surgically in womb. You'd have to wait until after the baby is born, right?
Right.
Okay. So I think the one of the things that we wanted to get out there too is that we work closely with Barrow Clefton Craniofacial Center. Can we talk a little bit about that and kind of show what the relationship is there?
Sure. So our Barrow Clefton Craniofacial Center, which is based at the Barrow campus over on First and Thomas, is really been alive, active for over 30 years.
Wow.
And most of the transition of the volume from a surgical standpoint and a provider standpoint has happened as the partnership with St. Joe's evolved and the pediatric services were merged here.
Yeah.
But we continue to provide multidisciplinary team care from an outpatient standpoint through the Barrel-Cleft and Craniofacial Center. Those children all have their surgeries here,
Okay.
but there are over 20 subspecialists involved in the child's care, and many of them are providers here at PCH. And so we see them in a team format through the Cleft and Craniofacial Center, and then we see them individually on campus here in our offices as needed in between team visits, which typically happen annually.
Okay, and there's a lot of people that are get involved with this team, right? I mean,
Yeah.
just name some of the different specialties that kind of go into a child's care in that kind of that depth and breadth. So who are involved in that?
Everything you think of with the face. So there's ophthalmology for the eyes. There's ENT, who do hearing and nose and throat and swallowing issues.
Yeah.
We have speech therapists. We have social workers. We have nutritionists. And then there's all the dental people. So orthodontia and dentistry and coming up with implants and grafts and other things. It's a big team.
Yeah, and so who is typically a candidate for this? I mean, what is the kind of the typical, if there is a typical candidate for this kind of procedures or this type of care? What would it be? Or who
I mean,
would it
I
be?
feel that any child that has a craniofacial anomaly or difference,
Yeah.
whether it's facial asymmetry, whether it's lack of growth, and it doesn't only have to be birth anomalies, it can be related to trauma.
Oh, that's another area. I always
Right.
forget about that one.
Can be
That's
related
right.
to tumors.
Yeah.
There are a lot of more common tumor diagnoses or neoplasms in children, such as fibrous dysplasia. We have other facial bone tumors and skull tumors. Those children also qualify to be seen through a team because it can impact more than just one system
Yeah.
in their head and neck. So ENT, ophthalmology, neurosurgery, plastic surgery, we all work together to figure out what's the best care plan for these children.
Would you say though that the majority of the kids is birth, or is it a kind of a even with trauma, or like what is the typical one that you would see most of?
So most of them are birth anomalies.
Okay.
We just reviewed our volume through our Barrel-Cleft and Craniofacial Center, and it's about 65% pediatric, and then the remainder is adult volume.
Oh, okay.
Anyone over the age of 18 to 19, we kind of classify as adult.
Voting age,
And-
right?
Voting age, right? Not drinking age.
Right. I said voting.
And so the reason I bring that up is because we don't want our patients, our pediatric patients who have congenital anomalies, to feel that when they turn 18, we're going to stop taking care of them.
Yeah.
It's a lifetime condition, and they are lifetime needs that come up. And so we do see those patients also. And then, so if you look at the pediatric volume, the vast majority of that, 80 to 85%,
Yeah.
is congenital differences. And then
Okay.
the remainder are related to trauma, related to new growths or tumors that come up.
And when we say congenital, I just want to just identify what congenital is then, right? That's
From birth.
From birth.
Born with.
Okay,
Yeah.
got it. I just want to make sure. Okay, so when we talk about what we offer here, why should or why would providers refer to the care that we offer here? And then kind of the second part of that is why should parents feel that this is the place to go for that kind of care and these kinds of treatments?
So I think we put a lot of effort into this.
Yeah.
These are not just surgeries that you check off for us. This is something where we attend national and international meetings together, and we're trying to constantly stay up on the latest techniques and the latest advances in the field. And so this is something that we enjoy, and we, as I say, put a lot of effort into providing the best we can for
Yeah.
our patients.
Yeah. Do you want to add anything?
No, I agree. I think that both Dr. Bristol and I are very passionate about taking care of kids with craniofacial differences, as is everyone in our team.
Yeah.
And Dr. Stephen Beals, who's one of the co-medical directors of the team, has worked for many, many years to build this team, and it's very difficult to find providers who work together well and are part of the team, and to have the resources for patients to have access to these types of providers. And I think that the biggest benefit in my mind is the coordination of care for our patients. I think that in many centers you can find isolated providers who are excellent, but I feel like our excellence is only as good as it can get for the patients when we work together and not in isolation. And I think that if you said what's the single biggest reason that patients should come to us and should come to to the Barrowcleft and Craniofacial Center and to PCH is because of the team.
Yeah, well, you see, you set it up for me. You threw me the softball, and I'm going to hit it because we always talk about the multidisciplinary care, right? It's almost kind of the one-stop. We always use it the one-stop shop in a way, but I realize that you guys have been working together since 2008. So it's clear that you guys have this tandem approach. Talk a little bit about the fact that you've seen increases in your surgery volumes over the years. Is this just because you guys have become you're excellent at what you do? And I'm telling you this because we see the data, and you guys have been working together for a long time. So we're seeing that. Is it because providers and families are starting to learn more about what we offer, and they starting to learn more about that multidisciplinary care? Is that kind of the background on it too?
I think that's a large part of it.
Yeah.
I certainly am meeting a lot more families now who have either heard of us through other families or were given a specific referral from their primary care provider.
Yeah, definitely. And anything from
Yeah, I mean, I think that fortunately the internet has really opened up an ability for families to educate themselves before they even meet the providers. And I find that parents are very savvy in understanding the condition and what questions that they should ask, and they rightfully should be seen by providers who have large volume in treating that condition. It's not so common that you can go to any plastic surgeon. You want fellowship trained plastic surgeons, neurosurgeons, subspecialists within the craniofacial field to make sure that that provider has good volume and works in a team format to take care of the children.
Good points. So that being said, so neurosurgery, plastic surgery. Let's talk a little bit about how you guys work together in any case. As an example, how you kind of partner up in the OR. By the way, I've seen this. These ladies are amazing, and I do have to say that one time though it was great. I'm just gonna say
I have to chuckle because Peter was the only male in the room.
Oh, it was amazing. You know what? But I loved being there. These ladies did, and you guys gave me a little bit of business, but you know what? I can handle it. They were very good at what they do. But I think it's interesting to kind of see what I loved about it was just kind of seeing how you guys kind of just did this almost like tag team situation. Where one would step in, the other one steps out, and kind of vice versa. Talk a little bit about how that might work on a typical case maybe that you're both working on.
So I think we plan it together ahead of time.
Okay.
Then the actual surgery, I'm there to protect the brain.
Yeah.
And so as we're opening and getting things going, I'm there to sort of help with that part. And then when it comes to which pieces of bone to take off, she makes those decisions, and then I take them off in a way that's safe for the child.
Oh,
And
okay.
then-
So you're protecting brain, she's protecting aesthetics, basically. Is really what it comes down to, right? I know. I'm
And the brain.
I'm in the brain. I'm
And the-
oversimplifying.
And the eyeballs.
Right. I'm oversimplifying. But talk a little bit more about it because it's pretty amazing.
I mean, there's an art to it,
Yes.
and then there's the function of it, which is protection of the brain, making sure there's enough room with what I do with the reconstruction to accommodate the brain, what the long-term growth is for this child. And this is where Dr. Bristol and I discuss the child's care, coordinate, and if we feel like we need input from our ophthalmologist or our ENT colleagues, we get that input, we incorporate it, we determine a surgical plan. So we walk into that room with a surgical plan. We have pre-surgical imaging, pre-surgical discussions and evaluations that have been done.
Yeah.
And then the reason the OR flows so smoothly is because of all the team approach ahead of time.
Yep.
And yes, we very much, at this point, because we've been working together for so long,
We can
it flows
anticipate
well.
each other, right?
Right. And it's great to have that consistency of being with someone in the operating room.
Yeah.
And I always tell patients and families that it makes the surgery more efficient to be working with team members who are consistent,
Yeah.
right? And it's not just us, but anesthesia. We have a craniofacial anesthesia team, and their role is very, very critical in the operating room, and then also our nursing and OR staff.
Yeah, I mean, I do have to say we've done a couple patient stories. One's going to be coming out soon, but the ones that we've seen, I got to see a patient afterwards. That was I think it was like a month and a half or so afterwards. And when you see the surgery, it's quite extensive. Let's just put it that way. And that's my next question I'll ask. Well, there's different types of surgeries that we do for this, but seeing this patient afterwards in the exam room it literally was unbelievable to me, because when you see the surgery and then when you see the patient afterwards, so you guys just do amazing work. But I want to also ask, so there are different kinds of surgeries that you guys do, and there, to generalize it, there's kind of minimally invasive and then there's traditional surgeries. Can you kind of talk a little bit about what those entail and why you would choose those kinds of surgeries for different kinds of patients?
So, as with all types of surgery these days, things are evolving, and patients and providers in general are trying to move towards more minimally invasive or smaller opening things.
Mm-hmm.
Now, that doesn't necessarily mean that the job we do on the inside is any smaller.
Right.
It just means that the cut on the skin is a little bit smaller.
The entrance point,
right?
Yeah,
So for children that we're able to be nice and young, so that is 2 months or younger, we can plan what we call this minimally invasive surgery, which we do around 3 months of age, and that's because the bone is still soft enough to be malleable and to take the shape we want, usually in a helmet afterwards.
Okay.
Unfortunately, if we don't meet the children until after 3-4 months, then we lose that window, and then we have to opt for the more traditional or open approach.
Yeah, and I remember
So this
that,
is specifically talking about craniosynostosis, just so that everybody knows what we're addressing.
Yeah.
So for the craniosynostosis surgery, there are seams between the bone plates that have closed too early.
on the tops of the skull.
On the top, sometimes on the sides, sometimes in the front, sometimes in the back.
Yeah.
But the most common is the seam, the sagittal suture, which is from the anterior soft spot to the posterior soft spot, otherwise known as fontanelles.
Okay.
And but it affects the entire head shape.
Yeah.
And the minimally invasive approach, we're doing 2 small incisions, and we're taking care of the entire head. And by head, I mean the bone.
Yeah.
It's not brain surgery, it's bone surgery. We're
Right.
correcting the bone problem.
The brain case, basically.
The brain case, right? The envelope for the brain.
Right.
And it enables the brain to live in a happier configuration.
Yeah.
But that is what we term the minimally invasive. Now, it is dependent on using a helmet or a band after surgery to help guide the bone growth.
Yeah.
So those are surgeries that have evolved over the past 10, 15 years.
Yeah.
What you term kind of traditional surgeries, we term open calvarial vault remodeling surgeries, and that is
There's going to be a quiz on this afterwards.
Yes, we're going to correct all the terminology. But it's an ear-to-ear incision, and it's always interesting to me that you've seen the surgeries, right?
Yeah.
We go in there, we do so much work on the bone, we're completely reshaping the shape of the head, the forehead, the eyes, because we're doing the entire orbital region. But as the kids get older, what they say to me is, I don't like my scar.
Yeah.
And so that's where I feel like if we can catch the kids earlier on, if the referrals from the pediatricians come in when they're newborns or 1 to 2 months of age, then we can plan with the families to do, the minimally invasive, meaning the same degree of work on the bone, but through smaller incisions.
Yeah, but I that's a good point, because the other thing too, so I like I said, I the honor of seeing them work, and even to the point where, some of the incisions you're doing across the top of the head, and you're doing it kind of, in a jagged line, so that, you don't have to
Call it zigzag.
Zigzag, thank you. You never use jagged when you're a surgeon, I'm sorry.
No, it doesn't work well.
It doesn't work well. But, again, the aesthetic value of that, so when a child's swimming or something, you would see a division across, because hair follicles wouldn't grow in the scar and things like that. So that's the kind of thing, as if you're a provider watching this, or even a parent for that matter, that these ladies and the whole team are doing and taking into consideration these kinds of things, and especially from the standpoint too of just again, that expertise that you've been doing this a long time. So like you said, the experience level is huge for that as well. Let's talk about what the implications are if a child would not get this. So what is literally happening in the brain? It's getting pinched, it's getting keystoned in a way, and what would happen? What are some of the symptoms that a child might be having if they aren't being seen timely enough, in a timely manner?
So we do have patients who present late, or sometimes parents opt not to have surgery, which is not what we consider the standard of care for craniosynostosis in the U.S. And we see children who present late with very malformed head shapes. I'll let Dr. Bristol comment on the neurological implications, potential neurological implications.
Yeah, so there have been some studies that have found high pressure inside the brain in anywhere from 17 to 40% of patients.
Okay.
And so that's obviously going to vary based on just how severe that particular patient's case is.
Yeah.
But the brain has to grow so much from the time a baby's born until you reach adult size.
Yeah.
And if one of those seams or sutures is closed, you're going to lose a percentage of that growth. And so, sure, some people will be okay and they'll get away without it. and others won't. And the thing that's difficult is we don't have a crystal ball, and so
Right.
we aren't able to pick which patients are going to be fine without surgery. So as Dr. Singh said, it is considered standard of care to operate on craniosynostosis at this time to prevent those late problems.
And when we talk about problems, we're talking, it might start with vision, it might then headaches.
Those
What
are the
what how does it
common-
how does it escalate from there? Is it developmental delays later on, or
Right,
what
so
happens?
there's learning disabilities.
Yeah.
I think, it's, the recent literature shows that sagittal synostosis patients have some learning disabilities just because of that diagnosis, and earlier intervention decreases their risk for developing any type of delays and any types of learning disabilities. But attention deficit disorder, ADHD, focus abilities, in school. And so these things start manifesting themselves in the kindergarten, first, second grade time frame.
Yeah.
And that's kind of when the headaches start coming. So we've had a few kids with sagittal synostosis who've presented to us between 3 to 5 years of age, and what they say is headaches. But then you start finding out about behavioral concerns, and you find that there's more than just the headaches, but they're
Yeah.
all tied together.
Yeah.
And then, the other thing that oftentimes parents don't realize, that even though the premature closure is on the head, it impacts the entire facial growth. It impacts the orbits.
Yeah.
It can impact the joints. If there's a curvature to the face, it impacts the nose. And so that's where there's a balance in terms of reconstruction and timing of reconstruction, so we can try to more normalize that facial growth pattern, which happens
Yeah,
after
early
the
on.
head growth.
Yeah, and
Right.
because it's growing so fast too, right?
Right.
The sinus cavity, everything. It's everything is growing so fast at that point, right?
Mhm.
Well, let's talk about. So we do have the Head Shape Clinic, and that's where kids and families can come in, and if they're having any concerns at that point, what happens? It's kind of a go no go in terms of what the rest of their care is. Then.
So one of the things that I found in my first few years of practice is that a lot of pediatricians and other primary care providers have a hard time figuring out which patients actually have craniosynostosis versus those who just have normal molding of the head, or what we call plagiocephaly.
Okay.
And so that's something that's fairly straightforward for us, but we look at heads all the time, every day.
Yeah.
And I know that any given pediatrician may only see 1 or 2 real craniosynostoses in their career.
Yeah.
And so I wanted to start a clinic that I run with one of my nurse practitioners, Katie Class.
Mhm.
And it's meant to be sort of a relatively quick visit where we're just reassuring patients and families that no, your child is perfectly fine. This is just normal molding of the head versus, you're right, this is a condition that's going to need more attention and probably surgery. And so it's really kind of a screening clinic
Yeah.
so that we can catch people where there's some concern on the pediatrician side.
That's perfect. Now, one of the areas in craniofacial where we see kind of that night and day, before and after, might be the cleft lip and palate. Like, can you talk a little bit about that? Because some of the transformations there. So we talked about the craniosynostosis transformations, like where I saw a couple of patients after this major surgery, which it still blew me away. But then you get some of this reconstruction of straight on in the face that you do quite a bit of. Can you talk a little bit about that and why referring physicians might want to send them to you as well?
Sure. We see most of our babies who have been diagnosed with cleft lip and palate as in utero consultations.
Oh, yeah. Mhm.
And that is our preference, because we feel that the more our families are prepared, the smoother the transition goes with care, because the concerns start at birth, and the biggest concern is feeding.
Yeah, yeah.
Our babies with cleft lip and palate can't feed the way other babies feed because their palate doesn't function because of the cleft.
Yeah.
And so through our fetal care network here at PCH, we really work hard to have what we term in utero consultations for our families with plastic surgery, with our cleft and craniofacial orthodontist, and our feeding and speech specialist, both over at the Barrow Cleft and Craniofacial Center. And they only take care of cleft and craniofacial conditions.
That's
so you
all
say,
they do.
well, why not go to an orthodontist? There's so many orthodontists
Yeah.
out in the community. So our Barrow Cleft and Craniofacial Center is the only center in the state of Arizona, the only center regionally. So we get kids from West Texas,
Oh,
from
wow.
Nevada, from New Mexico, who
Okay.
come to our Cleft and Craniofacial Center for cleft lip and palate care.
Wow.
It's a process that starts as a newborn, and then surgery is typically done for the lip and nasal repair around 4 months of age, and then the palate, the roof of the mouth, is fixed at 8 months of age, and 8 to 9 months of age. And I always tell parents, by their first birthday, we want you to be able to have a regular birthday cake without worrying
See, that's
about
amazing.
the child's having trouble eating it.
Yeah, I mean, I think that's the thing too. Is that for someone that sees that, you know, we've all seen those pictures of those babies, and it's just a lot of times the lip looks so disfigured, but there's other things that are going on in the roof of the mouth, and I think a lot of people don't understand that. Well, if it's just the lip, you know, why can't the baby just feed like that? But there's a lot of other stuff going on inside the mouth at that point too. So I'm glad you brought that up too, and that when you can see it in utero, then you can kind of socialize that to the family so that they know kind of what the journey is going to be from that point on at that point.
Right. It really is. We have timelines established, recommended timelines for care for all of our cleft and craniofacial conditions, and that's available for any family whose child is diagnosed, whether it's in utero or after birth. But it helps set the stage for the families to educate them and to also prepare them as a family unit about what to expect for care and for surgeries in the future.
So with craniosynostosis and with like something like the cleft lip and palate, what is kind of the trajectory of those kids? You know, again, you see these amazing transformations, but are they pretty much in it for quite a while, a long haul? Is this like a 5-year, 7-year plan, or is it? And I know it's case by case kind of, but typically, where do you see the trajectory on those kinds of cases once they start having those early procedures done?
I mean, for the craniosynostoses, our goal is to really get them normal,
Yeah.
so that they can play sports, they can participate in other activities
Yeah.
at school, and obviously that's where the difference between syndromic and non-syndromic comes
Yeah.
in, where the non-syndromics tend to be more straightforward,
Yeah.
and very frequently it's just one surgery and then they're done
Wow.
and they move on.
Yeah.
We do follow them, you know, as she said earlier, into teenage years, adulthood even.
Right.
But we want them to really be able to participate in life normally.
Yeah, that's the goal there. What about the cleft lip and palate?
So for our patients with cleft lip and palate, we follow them into adulthood, but their last surgery has to be done when they're done with skeletal growth, facial growth. So
Which is about when?
So for girls, it's usually around 16, 17. For boys, it can be anywhere from 18 to 20.
Oh, wow, okay.
And what we're doing is we're having to plan out jaw surgery, and then after the final jaw surgery, to align their teeth, to enable them to breathe much better, because the septum is also shifted, and we're having to do nasal work and lip revisions. And so those surgeries really happen in the children with cleft lip and palate between ages 17 to 20.
Yeah.
And those surgeries are done here at Phoenix Children's Hospital. Just because they turn 18 doesn't mean we don't take care of them.
We talked about that with
Right?
Dr. Franklin,
And,
right?
so I just want to circle back.
No, that's
and,
good. I love that.
So we will, and you know, our goal as a craniofacial center and team is to make sure that our patients are always taken care of regardless of age. And I think for the craniosynostosis, just to touch upon, you know, the distinction between the children who have associated syndromes and those who don't. The ones who do have associated syndromes, their face doesn't grow. They have a lot of breathing issues, a lot of feeding issues, chewing issues. And so those children need more extensive facial procedures, like Lefort 3s, Lefort 1s, where the face is being moved forward.
I just saw that. I think when I was attending one of your other surgeries, there was a representative there, and he was showing me that, and I was just amazed that you can even do that. I'm just going to lead into one last thing here before we call it quits for the segment. But one of the things that was pretty amazing too is kind of some of the things that are happening in those kinds of surgeries, the pioneering techniques. And I asked you guys that, I think, when I was in the OR, and one of the things that you did say was the dissolvable plates and screws. I mean, that's kind of revolutionized that type of surgery. But overall, is there any other things that are kind of on the horizon from cleft lip and palate, from craniosynostosis, or are we kind of at a good plateau here of how we treat patients? You know, because you talked about you going to conferences and things like that. Is there anything on the horizon, or is that kind of where we're at this point?
I think one thing that we're really working on offering here is, I feel there's the age group, if we miss that window of 3 to 4 months for the early minimally invasive procedure, there is another procedure that could be done through a different surgical technique between ages 5 to 7 months before you say, okay, we're going to do the open approach.
Yeah. And
so we're looking actively, if we find patients in that age group, instead of saying, oh, well, we've missed this one window, now we have to go to the open approach, to bringing that, and it's called spring-assisted cranioplasty, where instead of But the downside to that, it's two surgeries. You do one surgery to put the device in, and then it's another surgery to remove the device. And the reason we haven't gone towards that procedure, even though it's been around for a while, is because we feel that our earlier minimally invasive procedure right now, it's one surgery and then the helmet.
Yeah.
But I think that would be an important thing to have to offer to our patients in that time window. And then I think that distraction osteogenesis, which we do also with devices, especially in our children with very complex craniosynostosis, is an area where we're always trying to push the envelope to figure out when's the best timing to minimize the overall number of surgeries for them.
Yeah, and then again, the helmet is something that is kind of an after care, and you guys, you even told me this too, where you can kind of shave that helmet to keep that head growing correctly, if you will. So what's the helmet made out of again? Is it some kind of a material where you can actually kind of shave it down on visit to visit?
So there are two parts of it. The outside is a very hard plastic, which kind of maintains the shape.
Yeah.
And then the inside is a softer foam.
Okay.
And so the foam is what is able to be shaved out, and that's what's actually up against the head. So it's not like having hard plastic right on the skin.
Right.
So that's a very important part of that procedure to keep that head growing in the shape we want.
How long does a child typically have to wear the helmet after maybe a procedure like a craniosynostosis procedure?
Somewhere in the 3 to 5 month range.
Okay, so and then by at that time you're seeing it forming well, and they can take it off then at that point? Interesting. Okay, cool. So that's all the time we probably could keep going and going and talking more and more, but they have to do surgeries at some point. So thank you, and thanks again for both being here, and thanks for rushing in from your trip. I appreciate it. If you have any questions, definitely go online, check us out, and we'll see you for the next Phoenix Children's Live. Thank you, guys.
Thank you, Peter.